Hi class, and welcome back to another lecture for Psych 101. Today we're going to go over the penultimate lecture, Chapter 15, Psychological Disorders and Treatment. So this is going to be a lot of information coming at you. I'm going to spend most of the time during class taking questions about different mental disorders or different types of treatment if people have questions, but I'm not going to be going into too much. So if you do have questions, I suggest you come to class with them. Thanks, Kat. But with that in mind, let's go ahead and get started. A couple quick announcements, right? I have office hours. We're getting near the end of the semester, so if you have any questions, now's a good time to come. And don't forget you need those SONA credits. If you're not done, there's a couple studies left, but you're running out of time, so make sure to get them done. The only other thing I'm going to mention about this today is beware this medical student syndrome. You're studying for an exam, or you're going over a chapter with a lot of things that take pieces of our lives in part. So for instance, things like anxiety. We all experience symptoms of anxiety or depression from time to time. Don't think because I name a couple of these symptoms that guarantees you have it. Don't fall into this medical student syndrome. So with that in mind, where are we going? Well, we've got a lot to cover today. So today we're going to cover what is a psychological disorder, how we can explain them, and we'll go into some different categories of the Diagnostic Statistics Manual 5, the 5th version of this, basically the Bible for a psychiatrist or a psychologist to go through and look at different mental disorders. Lastly, we'll talk about how we treat disorders and how this is an ongoing process still. But before we begin, one thing I want you to think about is, what does it mean to be a normal person? And how do we know what is abnormal? And how are these the same or different? So when we think about what is abnormal, we can think possible criteria, talk about how often this behavior happens, its frequency or infrequency. Does it go against cultural values or expectations or the norms that we have in a way that I guess is severe? And then does it cause personal suffering, right? Is there harm to self or harm to others? But this other type of harm that, right, maybe is a little less clear, this idea of causing you distress. So while you may not self-harm or cause harm to others if you are very anxious, it might be causing you distress. You might be losing sleep. You might be having difficulty eating or working or focusing, things like this. And I would say that is something to matter. But the practical approach that we actually use involves three different things. The impaired functioning, so how difficult it is to consider these appropriate and expected roles. So as a professor, if I couldn't do my job, we would say, right, I had a function impairment. I was unable to complete this. If you're unable as a student to do your job, that could be impaired functioning. You're not functioning as normal, right? You can't function normally. But to put everything else up on the screen, the three things that we actually focus on here are content, context and culture, in consequences. The APA, the American Psychological Association, puts these as things that are deviant, things that are distressing to the individual, and things that are dysfunctional, right? So not functional, that impaired functioning aspect of it. Because, for instance, right, I can absolutely be considered not normal if I decide to wear a penguin suit to class, right? But it doesn't cause any personal suffering. It's pretty rare that I do it. But right, there is no issues with my, right, this is maybe a deviant behavior, but it's not causing distress and it's not causing dysfunction. With all of this in mind, I think it's important to take a minute to talk about the idea of stigma, right? So we've spent some time talking about prejudice and discrimination, but there is a deep prejudice against people who tend to have mental disorders in this country, I think in a lot of countries as well. The idea that there's these destructive beliefs and attitudes held by society about certain groups of individuals. This, right, we have stigmas about different things, but the idea with stigmas are that we see people as different from us, going back to this minimal groups paradigm, that we are not like them, right? And typically this leads to discrimination. The idea that illusory correlations exist. Just because somebody might look crazy doesn't mean that everybody who has a mental disorder, right, is crazy or doesn't receive treatment for these. And this can prevent individuals from seeking treatment because they're afraid to be seen as this outsider, and how terrible this can be. So what I do want to bring up here is that mental health is something that is very stigmatized in this country. It's difficult to get treatment for, and it's seen as something that makes individuals weaker. I think this is something that we as a culture need to change, and need to change rapidly, in understanding that feeling having a mental illness, or feeling down or blue, depressed, anxious, all of these things is not something that should be worn as a badge of shame, but is, again, just part of life. We'll talk about how many people actually have mental disorders on average, in terms of the statistics of what we think. But moving on to how we can explain why mental disorders come up. There's a couple good theories in here, and I'm going to start off with a not so good theory. The original theory for why mental disorders happened was this supernatural model. The idea that abnormal behavior was due to possession by gods or demons, and this is where we see things like witches, burning somebody at the stake, or maybe weighing them next to a duck, if you've seen Monty Python. This is going to be more or less not seen as a very prominent scientific viewpoint of mental disorders in psychology. However, think about the movie The Exorcist. Stuff like this is still believed, but we wouldn't say that this is a primary cause of mental disorders. Now, apparently, I screwed up all of my slide here, but the second model that we'll spend some time talking about is the biopsychosocial model. So this is a model that covers three things: biology, psychology, social cultural context. Mental disorders are probably caused by the interaction of these three factors or forces. So our biological factors that might matter. Physical illnesses can actually cause us to feel bad. They can actually cause possibly some different changes in the brain. There is a belief that schizophrenia, no, I'm sorry, that's diabetes. Ignore me. Disruption of bodily processes can happen with biological factors. There's also genetic influences when it comes to things like health and mental wellness. But we've got psychological processes that we've spent a lot of time talking about: wants, needs, emotions, unconscious conflicts, our relationships, what we've learned, our current situations, and then who we are kind of in a social and cultural context. Our gender, our age, our race, if we're married or not, how our culture values certain things, our situations regarding our physical, social, and economic status. All of these things influence one another to kind of help us better understand all of these different factors that go into what make us us. And you can imagine, so if, say, you were having trouble with some of your psychological processes, your wants, needs, and emotions, it might cause you physical illness. It might cause you, to not feel well. It might cause you to maybe not eat or something. When it comes to these, additionally, your wants, needs, and emotions that aren't being met might be actually influenced by your sociocultural context. Imagine if you feel lonely, because of your age or wherever you are in life, that you don't have a partner or something like that, and how that might influence this as well, if we're talking about something like depression. Again, the biopsychosocial model, more or less, it's that all three of these factors influence one another, and together, that makes up a good model, or a believed good model, of mental illnesses. The last one we'll talk about is the diathesis stress model. And the diathesis stress model is, again, pretty easy. We're still talking about biological, psychological, and sociocultural risk factors. But the way we set this up is a little different. We can talk about this in terms of precursors. So genetic factors, if you have any brain diseases, if you have good or bad early learning experiences, or if you have things like bad family dynamics, all of this might lead to diathesis, or a predisposition for a psychological disorder. So say that there is a history of mental illness in your family, genetic factors. Say you maybe suffer from some sort of brain disease, as they say here. Say you have poor early learning experiences and bad family dynamics. Say you've just got all of this going against you. This might lead to a vulnerability. Maybe this doesn't necessarily cause you to be to show symptoms of this disorder, but what might happen is you might become stressed, right? Either your social stresses in life, stressful family life, which if you have bad family dynamics, it's probably there. If you have poor self-understanding or self-awareness, that might also lead to stress, which might cause this disorder. So all of this works under a slightly different model compared to the biopsychosocial model, right? The diathesis is a vulnerability. So we have some vulnerabilities, probably due to our genetic influences and our early life factors, that maybe if we have too much stress might cause a disorder to come about. But if, say, we didn't have stress, we might not get this. And say, if we didn't have these genetic factors, we also might not have this kind of mental disorder come about. So again, this is actually really stressing the idea of stress in this model. But let's go ahead and spend some time talking about some categories of disorders in DSM-5. The DSM-5 is going to cover a lot of different categories of disorders, and within those categories are some disorders that you probably are very familiar with just from general culture, right? So we'll talk about the category of anxiety, obsessive compulsive, and trauma disorders, right? This all falls under one category. We'll talk about some different types of anxiety as well. We'll talk about depressive and bipolar disorders, dissociative disorders, schizophrenia, and finally this idea of personality disorders. But with that in mind, it's important to recognize that these disorders are not equally likely to happen across or I should say they're not equally likely to happen, period. There are actually some disorders that are much more common and some disorders that are much less common. So we look at our percentage of people who have a psychological disorder here, and we break it down by what type. You see that the highest percentage, about 20%, of people with what we call psychological disorders have substance-related disorders. So this could be a drug user or a drug abuser, something like this. About 16% or so have anxiety disorders. Mood disorders is a little bit lower, followed by antisocial and schizophrenia. Antisocial and personality disorder, our first personality disorder on the list, and then schizophrenia. But these are, of course, not everything, and this is not always what we talk about here. There's some other factors to mention, but I think this is a good way to look at this and recognize that certain disorders are more common than others. But let's go ahead and start with anxiety, obsessive compulsive disorder, and trauma disorder. So with that in mind, I've got a picture of Michael Jackson, I've got a picture of Howie Mandel, and I've got a picture of Whoopi Goldberg. And each one of these three people has, or in the case of Michael Jackson, had a psychological disorder in the anxiety category. One had an anxiety disorder, one had an obsessive compulsive disorder, and one had a trauma disorder. And we can talk about this during class, but I'd like you guys just to think in your head who has what. And if you watch enough TV, you might know at least one of these. But besides that, anxiety disorders are typically the most common type of disorder that we would consider a psychological disorder. Substance abuse disorders are more of a behavioral disorder, right? Using too much of this is more of a behavior problem than an actual mental problem, though that could be up for debate. But some characteristics of anxiety disorders are excessive or unrealistic amounts of anxiety, right? It's long-lasting, right? And it disrupts daily functioning. Right, so this is going to cause a problem with us. What we see is that people use maladaptive behaviors to reduce anxiety, whether that be violence or excessive drinking or engaging in drug use. And all of these are the major kind of overarching ideas behind anxiety disorders. But we have 4 different types of anxiety disorders within this. Those 4 are phobias, this idea of a panic disorder, this idea of generalized anxiety disorder, and obsessive compulsive disorder, which has a little questionability in terms of classification. That is, I think, more of a kind of a nuanced point that the field is trying to make. But starting with anxiety disorders and phobias, right? Phobias are these ongoing and irrational fears of a particular object, situation, or activity. We often think about specific phobias, right? These fears that people have. And so this can be about snakes or flying on an airplane or being in crowds. As we see agoraphobia here, agoraphobia is the fear of being in crowds, which I think a lot of us have picked up a little bit of this fear, maybe not to a phobic level, but I certainly don't like the idea of crowds right now. We also have social phobias, a fear of being criticized or doing something embarrassing. I think this is a natural phobia for most of us to have, but certain people have a extreme aversion to being criticized or doing something embarrassing. Right? Agoraphobia, this idea of being away from a safe place, is one type of phobia. So we have different specific phobias, some of which you may have heard before, some of which you may not have. You don't need to know all of these, but just generally knowing some phobias is probably good, right? We have acrophobia, the fear of heights, gamophobia, the fear of commitment. Let's put the rest of them up here. We've got colorophobia, the fear of clowns, aphotophobia, the fear of snakes, consecoteleophobia, I thought I had that pronounced right, fear of chopsticks, and claustrophobia, things like the fear of small places. So when we talk about different types of phobias, it's important to remember that these are only about a specific thing. They don't typically cover, right, everyone or every situation, and they can be desensitized using some classical, classical conditioning. You can slowly desensitize people through systematic desensitization to get rid of these phobias, though they are difficult. And you can imagine some of these phobias are worth getting rid of maybe more than others. If you're afraid, and if you're so afraid to go into a closet that you have claustrophobia so bad that you're afraid to go into a closet to put away your clothes, it's one thing. But if you're afraid of chopsticks and you're not a huge fan of Asian cuisine, maybe we don't really need to worry about that. All right, so moving on to our next disorder, panic disorder. Now, panic disorder is different than generalized anxiety disorder. Panic disorder is being truly in a panic. This is recurrent, terrifying panic attacks. So having panic disorder means you are having frequent panic attacks. Now, if anybody else has ever had a panic attack, they're terrifying. You get heart palpitations. You might feel pressure or pain in your chest. People often say, my heart hurts like I have a heart attack or I'm dying. Dizziness, sweating, faintness, all of the symptoms of your parasympathetic nervous system saying, I'm in terror. I'm in fear. I need something to do. These seem to come without warning or cause. It's one thing to have a bear chase down for you and feel this way. It's another thing to be sitting there and then all of a sudden just going, oh, I'm terrified, right? One of the biggest things about this that really causes impaired functioning is an individual might worry whether or not they can even go outside anymore or go to their job because of this. So we would say this is deviant in the sense that it's not very common. It's disruptive in the sense that it's causing dysfunction, right? It's causing this person to lose functionality of their job. This is not, right, what we would consider generalized anxiety disorder, though. And with that in mind, what generalized anxiety disorder is, or GAD, is a long-lasting, lower grade, unspecified level of anxiety. So we all likely, if you're anything like me at this point, this has been a very stressful 6 months. I think we all have some level of generalized anxiety disorder right now, because there is an unspecified anxiety going on in the world. People might be irritable, have sleep problems, unable to concentrate. What is interesting, though, is anxiety disorders tend to be more common in women, but this is not the only rate. This is not only for women, and we do know that while women have a higher rate of generalized anxiety disorders, it is not at all uncommon in men. But next, let's talk about PTSD. So post-traumatic stress disorder, PTSD, can develop following a traumatic or terrifying event. So post-traumatic, after a traumatic stress. This is a disorder. Now, I want to be very clear. After a traumatic event, no matter who you are likely to have some type of fear and stress about the situation. I've been in 2 car accidents in my life, both of which were caused by me, and I was very, very nervous to sit behind the wheel of a car for a couple weeks afterwards. I was very stressed. I was very nervous. When I had to go in to buy a car after I totaled my previous car, I didn't even think I was going to be able to drive down the highway to test the car. And that's pretty normal. But the idea would be that if I never got over that fear of driving because of this, that is probably part of PTSD, because that would be causing a extreme impairment on my life. Now, PTSD is lasting and frightening thoughts and memories. People tend to be emotionally numb or angry. This used to be called shell shock. So here's a picture from World War I of a guy who has what they call the 1,000-yard stare. Tend to be this kind of lack of emotion, or in his case, this kind of just scary look in his eyes. And we see this thing that with PTSD where people try to avoid anything that reminds them of the situations. They might get hyper aroused. They might begin to get into the state of fear. They might re-experience, these kind of repetitive thoughts of this, as well as negative thoughts, things probably like, am I ever going to get over this? And PTSD has been shown to be probably a lot more common than we had previously realized. One thing to note is that for some people, a traumatic event to one person is a completely non-traumatic, non-trauma-inducing event to another person, even things like car accidents. This is just an individual difference. So I want to be clear when I say, if you feel or if you see somebody who seems to have some of these symptoms or be struggling, being able to talk to them feel like you can reach out is a good thing. For a lot of these, I think that's worth mentioning, but I know with PTSD, people typically tend to seem like they change as who they are. But enough with PTSD, let's move on to OCD. So obsessive compulsive disorder, these persistent obsessive thoughts in this kind of compulsion to do something, this compulsive, repetitive, ritualistic behaviors. Characterized by our obsessions, so these unsettling or persistent thoughts that cause anxiety or distress. Did I lock the door? Did I lock the door? Or, if I don't lock the door correctly, somebody's going to break into my house. In compulsions, ritualistic, repetitive behavior that a person feels will reduce their anxiety. So, if I have an obsession about having my front door locked, I might lock my door 20 times until I, quote, get it right, which is a certain way of doing something that the person might agree with. So some examples, you probably have figured out that Howie Mandel was the person I was discussing who has OCD. But other movies, things like As Good as It Gets, the show Monk, What About Bob? These are all pretty common examples of OCD. If you've seen any of these, you would probably be able to tell this. But speaking of OCD, let's talk about common obsessions and compulsions. So people with OCD might have an obsession with dirt, germs, and chemicals, and this obsession often leads to the compulsion of washing. So washing hands, washing whatever you need to. Some people have an obsession with imagining harming the self or others, and this often leads to behaviors like repeating, so usually repetition of either things, doing specific things, or like counting or repeating sentences, phrases in your head. Some people are afraid they're going to lose control over their aggressive urges. And now understand, this is an obsession, that you are obsessionalizing over this. So almost like you're trying to not become the Hulk and afraid that you would one day. It often leads to things like checking, making sure everything's okay. Intrusive sexual thoughts or urges often leads to touching different things, not necessarily in a sexual manner. And then lastly, a need to have things just so. This kind of what people call OCD, this kind of neatness that we have. This often leads to things like hoarding or saving. So those are the 4 disorders we'll talk about regarding anxiety. But where do these come from? Well, with anxiety, if we think of this from a biological standpoint, these tend to run in families, it seems like. Even things like phobias. It could be that the nervous system gets oversensitive to stress, maybe a hair trigger on the fight or flight response. Could be. From a psychological perspective, environmental stresses often happen. I think we can all agree that the environmental stress of coronavirus has made us all a little bit anxious. Learned behavior. So if your parents teach you to be afraid, or your parents are deathly afraid of snakes, you will likely pick up on that. This could lead to things like irrational thinking. So you might magnify this. You might I would consider magnifying to be this making mountains out of molehills, to take a small problem and blow it up and think it's the worst problem in the world. A set of all or nothing thinking. Either I get an A on this exam or I'm an idiot, right? So I get all or I get nothing. Overgeneralization. So this idea that, I'm anxious about this because I'm just bad at school, period. Well, maybe you're good at some subjects and poor at others. You overgeneralize. And then lastly, this minimization. Even if you do something right, well, it wasn't that good anyway. Now, another thing we can talk about is this anxiety disorders regarding the causes being regarding biopsychosocial model. So this assumes that the biological, cognitive, and sociocultural factors combine and interact, as we said. So somebody may have a genetic disposition, but the disorder doesn't develop unless the right environmental trigger occurs. So if we think about this in terms of the diathesis stress model, it could be some type of stress, or it could just be an extreme amount of stress. It could be at a negative situation. It could be just about anything. So one thing I'd also like to mention is this idea of comorbidity. This idea of the existence of 2 or more disorders at the same time. Co meaning together, morbid in the sense of having this illness. And what we see is that there is a good chance that an individual will have a comorbid illness if they have a disorder. And it seems to be the case where anxiety is one of the most common either original disorder or the common comorbid disorder. So I think it's important to bring this idea up here. So we will talk about a lot of different disorders here. The next ones we'll talk about are kind of in this vein of depression, which is often very comorbid with anxiety. So worth discussing and understanding how these fit together. When you look at the symptoms, this often makes a lot of sense. But I think the most incredible thing is, from my last check, is that 46% of the population of the world, so approximately rounding down, 3.2 billion people are going to suffer a psychological disorder in their lifetime. So, 140 or probably 150,000 Americans by now. That's a lot of people. And 27% of people will experience more than one. So it's important to understand that this is a common problem, or having a mental disorder, as we define them, is a common problem. However, one, they don't last forever, and 2, they're a lot more common than people recognize. But with everything we've said regarding that, now let's move on to these depressive and bipolar disorders. Somebody like Abraham Lincoln had a depressive disorder. We've got J.K. Rowling, Jim Carrey has a bipolar disorder, has come out and said that. But when we talk about this, I'm going to use this chart for a second. So when we think about our lives and we think about how happy we are, right? Depression is a mood disorder. So it's about our emotions and our feelings and our mental affective state. And so when we think about our lives and we think about our emotional state, we can think about this on this continuum, right? If this is kind of even, say this is a neutral mental state, we might have some really good days, some bad weeks. If this is a year-long thing, right, we might have some okay weeks, but we probably kind of go up and down and stay towards the middle. Some days will be really good, some days will be really bad, but this makes a lot of sense. The important thing to understand about depression is that what you are doing is quite literally depressing. So but what I mean by that is you are pushing or depressing or shrinking the range of this happiness, sadness scale, the range of affective responses, the range of emotional responses. Depression, somebody with major depression disorder, if they plotted every day, their emotional state might look something like this. Now, we have a little bit of happiness here and here. These were pretty good days or weeks or whatever they might be, but we are filled with a lot of unhappiness down here. So recognizing that depression doesn't necessarily mean purely sad, especially when we talk about bipolar disorder. We'll be a little more clear on that. But recognize that when we think about depression, we are talking about usually this idea of a mood disorder. So with major depressive disorder, and you don't need to know all of these, just I would generally know the kind of idea behind the symptoms, but don't feel like you need to memorize all these. People are expected to have 5 of the following symptoms at least for at least 2 weeks. And one of those 5 symptoms must either be a depressed mood, lower mood, or diminished interest in activities. Some other things you might see, though, are appetite disturbances, either eating much more or much less, sleep disturbances, waking up or sleeping a lot more or sleeping a lot less, feeling restlessness or sluggish, feeling like you're losing energy, like you're tired all the time, feelings of worthlessness or excessive guilt, diminished ability to think or concentrate, and theoretically, another one that we can talk about is this idea of recurrent thoughts of death or suicide. It's very important to understand that this is a severe disorder. Suicide is one of the leading killers of younger people. So I just want to be clear, if you do feel like a fair amount of these symptoms fit with you, seek help, come talk to me, anybody else. That's for this or any other disorder. Another type of depressive disorder is this persistent depressive disorder. You may have also heard it called dysthymia. It's similar to major depressive disorder, but we consider it more lower grade. And this must have lasted 2 years. So instead of looking like this, a person with persistent depressive disorder might look a little bit better. I mean, they're still not exactly happy, but they're not extremely low in terms of their mood. I like to think of something like this as more like Eeyore, who was never greatly happy, but wasn't exactly extremely upset either. So moving on to bipolar disorders, some people who have had bipolar disorders have been open with this include Tim Burton and Van Gogh, actually. Probably hence the reason he cut off his ear. But bipolar disorders are well known for this idea of alternating between 2 poles of extreme emotions. Now, what I want to be clear about is when people say, oh, I'm so bipolar, they're not actually saying the right thing. Bipolar disorder only tends to happen with an episode about 1 or 2 episodes per year. So maybe a flip like this. And this tends to be a depressive episode. So what we've talked about with this kind of stuff down here at the bottom, and a manic episode. So a manic episode is this inflated self-esteem, decreased need for sleep. Right. This is kind of like somebody who's just straight up really had too much caffeine, right? Very flighty in terms of what they want to do, distractible, and sometimes you'll see these people will stay up for days at a time. In terms of what causes these mood disorders, there are biological factors such as genetics, right? We know that twins are more likely to have the same biological or the same mood disorder if this is something that runs in their family. There could be neurotransmitter imbalances. We know that serotonin is very important when it comes to happiness and depression. We know that your biological clock can actually be affected. This is the idea of seasonal affective disorder, or SAD. How great that a disorder about feeling sad for seasons is shortened to SAD itself. One thing you can do for that, those weren't supposed to come up together, is actually use specific types of lighting to help that. But psychological and cognitive factors that promote these mood disorders include things like distorted thinking, so thinking that things, again, right, this magnification or kind of minimization of these certain things. Learned helplessness as well, which, to talk a little bit about this is the belief that we're unable to change negative events, that the failure is just gonna happen no matter what, right? And what we see is that people who are focused on responses to failure, they tend to not learn how to help themselves. So for instance, if an uncontrollable bad event happens, you're going to focus on that perceived lack of control and generalize this to helpless behavior. So for instance, if you do bad on an exam, you might focus on the uncontrollable aspect, right? The professor made the exam too hard for me. This is just too hard, I can't do anything. That perceived lack of control might lead you to think, well, there's no worth trying in this class. And that, we know, is not going to be helpful at all, right? This guy here has a great example of talking about these focused responses to failure, that he might think, well, if I'm going to fail, why even bother getting out of bed, which is likely going to lead to his failure. So this is a very important thing to understand because learned helplessness really is something that seems to be a key factor in feeling depressed or having mood disorders. So moving on from there, let's talk about dissociative disorders. So dissociative disorders are dissociating from oneself or their memory. So this may be a break in memory, consciousness, or an identity. This can be caused by a fugue state, this inability to recall personal information or important information, right? Who you are, right, where you live, what you do. And this is too extensive to be explained by ordinary forgetfulness, right? You normally don't forget who you are. And oftentimes this leads to dissociative amnesia, right? A sudden memory loss that can occur without fatigue. And this is often things like the born identity. We also have dissociative identity disorder, which was formerly known as MPD, multiple personality disorder. Now, this is an incredibly rare disorder. The movie Split makes me very upset because this is not at all realistic. This is a report of having more than one identity, more something like Dr. Jekyll and Mr. Hyde, rather than having 12 different right, identities within you. So what causes dissociative disorders? Now, this one is talking about a specific type of therapy, which we'll talk about later. This psychodynamic therapy thinks that dissociative disorders are brought about through repressing threats, trying to hide away these threats that you might have. From a cognitive or behavioral standpoint, this is a thought avoidance and possibly the attention aspect of this. And with a biological, there seem to be different activities in different brain regions, which is really unique, right? That there are these different regions of the brain that are affecting these things differently. And it's incredible to see when people, right, theoretically switch these personalities, that different brain regions are activated, giving some credence to this as well. So again, I'm just trying to quickly go through this. This again should be something more seen as a tool that you can get an idea of what's going on, and I hope that class is going to be a bit more extensive in talking about this. But moving on to this idea of schizophrenia. So schizophrenia is mostly is best diagnosed by this idea of being unable to distinguish what is real from what is fake, and often comes with disturbed thinking, problems with emotions, and issues with perceptions and behaviors. Now, what we know is that most people who get schizophrenia will have it by about 26 or 28. It tends to come into onset around adolescence and usually in the mid to late 20s at the very latest. One thing that does increase the likelihood of this happening is actually using marijuana. We know increases the likelihood of a person who is if you think about it in the diathesis stress model, that using marijuana might actually be considered a stressor, which leads this vulnerability to kind of cause schizophrenia. Ch15 means break. I believe it's a German word. I'm not quite sure. Right, this break from reality. And Louis Wayne was a painter who supposedly had schizophrenia. He liked to draw pictures of cats, and this was his progression throughout his life of different cats. Again, this is not exactly a great example of what schizophrenics see or feel, but this kind of idea of unable to distinguish reality from fantasy. As we see, we move on and on. Now, some symptoms of schizophrenia, we have two types. We have positive symptoms and we have negative symptoms. Now, in the same way we talked in learning about positive and negative reinforcement and punishment, we have symptoms that are not good, period. These are all bad. Positive symptoms are not good. Positive symptoms add something. Negative symptoms take something away. So when we talk about positive symptoms, we're adding these thoughts, disorganization, we're adding hallucinations, we're adding things that aren't there, adding delusions and disorganized speech. With negative symptoms, you will see a reduction of speech, flat affect, so just kind of talking with no real set of emotion. How's it going, Kyle? It's going okay. Things are fine, right? Social withdrawal, pulling away from other people, and this kind of absence of pleasure and motivation. Now, notice some of these, right, specifically absence of pleasure and motivation, and maybe social withdrawal, are similar to some things we might see in an individual who has, right, a panic disorder or has generalized depression. These are, right, all symptoms that, again, can overlap and are pretty similar in terms of negative effects on people. But going through these symptoms of schizophrenia in a bit more detail, we can talk about disorganized speech, neologisms or new words we can talk about, right? Loose associations, clang or word salad, right? So if we talk about neologisms specifically, I've highlighted a couple here. This is an example from, actually forget who, I think it was John Nash from A Beautiful Mind who had talked about this. I'm here from a foreign university, and you have the plausity of all acts and of amendments to go through for the children's code. It is no mental disturbance or putinance. It is an amoration of law, like it is their pravat Some of those words aren't real, but this guy sounds smart. I'm just going to kind of agree with him because maybe I just don't know those words. But so you might see a person with schizophrenia make up these words. You might see them create loose associations, a series of ideas that are presented with loosely apparent or completely unrecognizable logistical connections. Right? He went to the ballpark and bought Frank's beer belly home with bag of grass seed. Like ballpark, Frank's hot dog, drinking beer are all things that happen at a baseball game. Beer is related to belly, right? Home plate, grass seed, grass is on the field. So this is something related to maybe baseball. Again, a very loosely presented series of ideas that's very hard to follow or understand. This idea of clang, right? Words are chosen from their related sounds rather than their logical meanings. This one sounds like you could get a pretty good beat over it, right? Never ever will you find the lever, the eternal ever that will sever me forever with my real seal deal heel. It is not on my shoe, not even on the sole, it walks away. That's the best I've been able to do that. But again, that makes no sense. More or less, right, they're kind of using words that just rhyme. And this is going to be something that's not exactly great. So with symptoms of schizophrenia, the last one I want to talk about is this idea of word salad, or random words or phrases mixed together in often unintelligible manner. So, right, word salad is the idea of you got some words floating around in your head and we're just kind of mix them up and throw them out, right? So dogs sleep, chicken pencil trees, wetness, smooth dancing sheep, living nectar of bees of pollen, butterflies run amok. That makes no sense to me. Random words or phrases that are linked together, right? This is all just kind of random. At least with loose associations, we had something that seemed to fit here. But again, right, this is somebody who is just kind of saying the things that are coming to mind. With disordered thinking, though, something else I think we ought to spend some time talking about, these delusions or false beliefs about the world that a person holds, and they tend to remain fixed even when faced with contradictory evidence, right? So you might believe that you're being influenced by things. You might have a belief of this grandeur that you're amazing. So this is John Nash, who had schizophrenia. Right, if you've seen A Beautiful Mind, he was offered a prestigious position at a university as the head of a department, and he turned it down because apparently he was about to be crowned the king of Antarctica. So, right, he had these delusions of grandeur. There's also this delusion of persecution people might have, this idea that everybody is out to get them, whether that be the aliens, the government, what have you. It's often things like aliens, the government, God, or demons. And this is all kind of falling in this disordered thinking. Now, in terms of causes of schizophrenia, we see that there is a huge biological factor of this, right? There is like a 45 to 48% chance that if your biological twin has schizophrenia, that you are going to have schizophrenia, almost a 50%, right? This could be inherited. There might be brain abnormality, as we see this in different fMRIs and MRI studies. Talk about psychological and social factors as well. The learning experiences that people have may make this more or less likely to happen, as well as stress, talking about things like the diathesis stress model as well. Lastly, let's spend some time talking about personality disorders before we move into treatment. So personality disorders are long-standing and inflexible ways of behaving that create problems. And these begin in childhood or adolescence. And I have 10 of them divided into 3 clusters. I put up this question, are these considered mental disorders? Maybe you would say these people are just odd, but maybe you would say these people have a mental disorder. It's not exactly clear cut. And right, we would say this is a problem, but I've often heard of this as almost kind of a different type of problem than the previous disorders we talked about. So the cluster A, the first cluster we'll talk about is the odd/eccentric cluster. So people who would be considered odd or eccentric, and specifically a paranoid personality disorder, somebody with this, might be very suspicious or distrustful of others and assume that other people are hostile. And then we have 2 that are pretty similar. We have a schizoid, which are the negative symptoms of schizophrenia. Right, so socially detached, restricted emotion, that flat affect. And then we have schizotypal, the positive aspects, symptoms of schizophrenia. Interestingly, though, they both lead to social detachment, although it might be odd thoughts or behaviors. The schizotypal specifically tend to not be disturbed enough to be diagnosed as schizophrenia, really, more than anything. If you guys, I don't know how much you know about chess or anything, this is... I can't think of his name, Bobby Fischer here. And then you've also got Mary Shelley, who wrote Frankenstein, the original one. She is believed, based on her writings, her diary, etc., that she likely had schizotypal disorder. Now, the second cluster of personality disorders we'll talk about are the dramatic/erratic cluster. So the first one we'll talk about is histrionic personality disorder. So histrionic personality disorder, right, I always think about, right, Paris Hilton as kind of an example of this, right, an excessive, well, maybe not excessive emotionality, but this idea that you must need to be the center of attention, possibly emotionally shallow, and recognizing, right, that you need to be the star of the show. Now, we've also heard of narcissism. One thing I actually want to mention before I talk about narcissism is that histrionic personality disorder used to only be diagnosed in women. However, this has changed because there are differences between histrionic and narcissistic. So with narcissistic personality disorders, this is exaggerating one's own importance, being arrogant and lacking empathy. So while you may want to be the center of attention as a narcissist, you are not willing to do certain things that a histrionic person would do. So a histrionic person, if they saw that the center of attention was being taken away from them, they might fake, like very obviously fake having an issue, like I'm feeling ill all of a sudden, can you help me? Or like, hey, everybody look at me. Or they might do something that's really negative to get the attention back. They might hit somebody just to get the show back on them. Versus a narcissist may want to be the center of attention, but they also want to be the good guy or the liked guy or the smart guy or girl in the room. Now, borderline personality disorder is what people think of, or what people are technically referring to when they say, oh, I'm so bipolar, right? This idea is an intense, emotionally unstable person who has difficulty staying in relationships, tend to be impulsive, suicidal gestures, and angry outbursts. Their emotional state can change from extremely happy to extremely upset at the drop of a hat. So going from, oh boy, I'm really happy, to, oh my God, my life is over, in the matter of possibly minutes. Now, the last one as well is antisocial personality disorder. Now, this, again, is another one I'd like to get on my soapbox about that people incorrectly label. When you don't want to go out and you want to stay at home because you are antisocial, quote unquote, you are being asocial. In the same way that asexual is lacking, right, sexuality, asocial is lacking wanting to be social. Antisocial, right? If you tell me that you're antisocial, you are somebody who is probably want to, hurt other people, right? Having a lack of remorse, maybe this superficial charm, being willing to violate other people's rights. Oftentimes, we would say that a person with a psychopathy or a psychopath or possibly a sociopath has these antisocial tendencies. Right? Being willing to do these terrible things, right? So an antisocial behavior might be bombing somebody or doing something against humanity or kind of our social groups. And the last cluster we have is the anxious/fearful cluster, which has a couple different ones. We have the dependent personality disorder. So this excessive need to be taken care of, this kind of submissiveness or helplessness. The obsessive compulsive personality disorder, which is different than the obsessive compulsive disorder. A obsessive compulsive personality disorder is a preoccupation with order, control, and cleanliness, but not to the extreme of OCD. So you can be like some people and like to keep things neat. Absolutely. You can really take it to extremes and have OCPD, personality disorder, right? But still maybe manage to function a little bit. And then at the most extreme version of this, you could have OCD, which might cause an extreme burden in your life. So being really clear on here that obsessive compulsive has two categories almost. The obsessive compulsive disorder, so the full thing, versus the obsessive compulsive personality disorder, which maybe is a little less extreme, but still a severe cause of problems. The last one we'll talk about is this idea of avoidance, and these people are people you would probably never see, right? They might be oversensitive to criticism, they might feel inadequate, they might have an inhibition regarding social situations. You know, they're not people you're really going to see very often. Okay, so with that in mind, what I want you to do is think about everything we just talked about. I would highly suggest taking a break for your own mental sanity, because we're about to move on to the treatment of psychological disorders. So go ahead, take a little break, and we've got probably another 20-ish minutes of slides to go. All right, treatment of psychological disorders. So when it comes to treatment, how do we decide? Well, it depends on what we see the source of the disease as. So if we believe the source of the disease is magic or demons, we should use an exorcist. If we believe that it's caused by biological factors, we might use a lobotomy, electroconvulsive therapy. We might use things like different types of drugs. So things for our neurotransmitters. Probably not something like heroin or cocaine, but again, prescribed drugs. If we think this is from psychological causes, we might use therapy. We think this is from sociological causes, we might use group or family counseling. We might use community psychology. In terms of the current treatments we typically see, it's a lot of psychotherapy and biomedical therapy. So I would say the bio, psycho, and social three here. So again, not really exorcism, unsurprising. So regarding treatment, we're going to talk about psychotherapy, a couple different versions of that, and we're going to talk about biomedical therapy and a couple different versions of that. So with psychotherapy, let's start there. Psychotherapy is the treatment of mental disorders by a psychological rather than medical means. So typically thought of as talk therapy. It's usually 30 to 50 minutes in length, and it can be short-term or long-term. Typically you see a therapist once a week, once every other week. And just some important information to know is therapists just are like anybody else. You might have a certain person you like to cut your hair, and in the same way, you might have a doctor you like or don't like. Therapists, right? It's important to find a counselor or therapist that's right for you. It might not be the first person you see. Right? Progress can be slow, and different therapies work better for different people. And we'll talk about what some therapies are good for and what other therapies might be better for as well. But I think it's very important to understand that at least. So let's start with psychoanalytic therapy. So psychoanalytic therapy comes from Sigmund Freud. Right? So going back to all of this, the assumptions behind this are people are driven by sexual and aggressive instincts. These conflicts with our id, our ego, and our superego that might cause us all these anxiety problems in modern day. This theory or this kind of approach expects you to explore your childhood events, as a lot of problems supposedly come from childhood. The goals of this understanding, the goals of this are to just understand what's going on in your head unconsciously, your thoughts, emotions, and conflicts. A therapist, on the other hand, is going to be considered a neutral expert. They're not really, they're more or less just sitting behind you, listening to you, taking notes, and trying to understand and fit this into what they know. But how do we get to the unconscious, right? Well, we can use hypnosis. We can ask people to interpret dreams. We can use things like free association. We can also use things like Freudian slips. If you've heard of these, I have a good example of this for the video. And then there's this idea of transference that's very important to talk about. So sometimes what happens is a therapist will act as whatever they're kind of as who the person, the client needs. So if you were having issues with your mom, a therapist might stand up or might kind of sit there and have you talk to them as if they were your mom. But this could cause transference, right? This idea that maybe now I start to think of you kind of like my mom, my therapist in this case. This is going to lead to some problems, especially if the therapist gets what's called countertransference or starts to feel really positive towards their client. I'm feeling like, well, if they think I'm their mom, they're kind of like my kid. And this is not something that's good, but there is, it's very well taught in psychotherapy to avoid this idea of transference. Something interesting to talk about, though. Now, there's some issues here, right? There's a lack of scientific research that backs this up, and it's probably not true that every problem has to do with sex. But what we know is that psychodynamic therapy is usually short in duration, but if the client is intelligent and verbal, is able to reasonably explain their problems, this is pretty good. This is also really useful for things like adjustment disorder, anxiety disorders, and interestingly, dissociative disorders, generally just the non-psychotic disorders. A second type of therapy, and probably one of my favorite approaches, is the humanistic and positive therapy. So this takes a completely different route. The assumption here is that this disorder is due to a failure of your innate drive to grow, that you have stalled out for some reason. Like, why are you burnt out and not wanting to try harder? And it's due to a focus on subjective interpretation and perception of events. Now, this goes back to Maslow, Maslow's hierarchy of needs. It shows up again. The goal with this therapy is to get people to accept themselves, to remove any blocks they have towards actualization. So, if you're getting stuck on, I don't think anybody loves me, a therapist might help you to get that love and belonging need, or to work with you to for you to get that love and belonging need to move you up the chain, restart this natural growth tendency to go out and do things, and to grow and better yourself. In the therapist's role here, instead of the therapist being a neutral expert, the client and the therapist are considered equals, right? You both look at each other and talk to each other and treat one another with respect. Now, this idea comes usually from a person-centered therapy approach, where growth for this individual is facilitated through genuine reactions from therapists. And this goes back to when we talked about unconditional positive regard, that therapists are there for their client no matter what. Said, I did something really stupid. And the therapist would say, you know what? That's okay. Don't worry about it. Like, I still respect you as a person. This is this idea of empathy, right? An emotional understanding of someone's experience, even if you didn't go through it, right? This difference between sympathy and empathy, right? I maybe haven't experienced what you've experienced, but I could imagine it's tough on you. And lastly, this idea that's you really can't fake, right? This idea of authenticity, being open, genuine, and honest, and being willing to share and, not be judgmental. Now, right, if I was a therapist and a client came in and said, I've done this terrible thing, I cheated on my wife, it might be hard to have an unconditional positive regard for somebody like that. But what you have to do as a therapist in that setting is be able to say, so, right, that's probably not the best thing. That might hurt your relationship. Have you discussed this with her? But again, right, say like, so why did you feel that you needed to do that? But not saying stuff like, wow, that's a terrible thing. Although it might be, right, lacking this judgment, even though it's not necessarily good. I have a couple friends who do therapy. They were in my research program, and boy, have I heard some stories about some crazy things, and they just take it all in stride. It's pretty incredible, and it takes a certain type of person that I don't know if I could ever be. But with this humanistic and positive therapy, the client might say things like, I wish my expectations were lower. Thinking about next year keeps me going. And this might be, well, how do I respond to that? Well, a therapist might say, it must be rough to face reality when your dream world provides an escape, right? This is a great way for that person to reframe what they said in an empathetic way, but still say, man, that must be hard on you. The client might say things like, I don't know why I waste your time on this idea of not feeling really positive, but a therapist is going to use authenticity, right? This isn't wasted time to me. I enjoy our sessions. I think it's good for you to see me when you're able to. And I think this is a lot of good, right? You could say a lot of things there that maybe wouldn't be as helpful. The interesting thing, though, is this is a very hands-off approach. It's very non-directive. You ask the person to kind of talk, and you see what they say. Little experimental research has gone into this. We do need clients to be able to express themselves and kind of understand themselves to the point where they know or have some idea what's causing them problems. Now, we know this is used for various psychological disorders. It's very helpful with people struggling for career choices or having issues with work or marriage counseling. These are very good approaches as well. Now, the last one we'll talk about regarding psychotherapy is these three types of therapies that all go together, right? So cognitive behavioral therapies will be the combined behavior and cognition therapies, but then we'll talk about them each individually first. So the assumptions with this are that people's actions are based on what we've learned, what we've been conditioned to, think about B.F. Skinner, in our past. The goal is to use classical or operant conditioning with behavior-focused therapies using our classic principles, right? Here we see systemic desensitization, or excuse me, this that's not desensitization. This is just an example of, right, training a bird to do something here. The therapist's role is going to be the teacher here, or the trainer. So with this, we focus on changing maladaptive behaviors into more constructive ones. So maybe, right, being angry or having issues on the potty. What we do is we use behavior modification, eliminating unwanted behaviors and promoting desired ones. How do we do this? Well, we reduce unwanted emotional responses through either exposure therapy, which we can do one of two ways. We can do exposure therapy as a kind of graded thing. So say you are afraid of spiders, What we can do is talk about systematic desensitization, where we kind of start you off at like the least scary version, right? Just dip your toes into the pool before we, keep going. On the other hand, we can use exposure therapy. Well, that one I will say is more graded, right? It goes at a kind of a slope, or we can just flood it, right? The equivalent of sink or swim. Oh, you're afraid of spiders? Well, here's a spider. Good luck. Like, maybe not the best way, and probably not what they actually do, but a more extreme version of this. So this might work for certain things that maybe somebody can do. Right? Maybe if you want to get somebody to stop being afraid of flying on planes, you just put them on a plane. Not sure that that's really going to work, but it is one way we can do this. There's other tools, things like aversion, modeling, token economies, contingency contracts. All of this stuff is a little bit too nuanced that I'm not going to cover here. If you do have questions, though, more than happy to chat about it. But up next, let's talk about cognitive therapy. So this is focusing on identifying and correcting distorted thinking about the self, the others, or the world. So again, purely mental here. So we might use cognitive restructuring. So replacing irrational thoughts that aren't exactly logical with realistic thoughts. So you might have an event that causes you to have an irrational thought, taking a final exam. You might have some irrational beliefs. I'm stupid. If I don't get an A, I'm worthless. Boom, you've got your all or nothing thinking. You've got your kind of minimizing here. But what you can do is you can train yourself to slowly stop using those thoughts, right? Replacing it with a realistic thought. Well, I'm going to try to prepare. That's the best I could do. And if I don't get an A, the world's not going to end. You can also do stress inoculation training, right? Practicing new thoughts about stressful situations, right? Imagining. So what are you going to do if you get into a situation where you get really stressed about an exam? And so this is going to tell you what you possibly should do. Here they have the example of, right, imagine what you would do if this is a real spider and tell me how you would walk through that. So you can see that this is going to be useful in the sense that we're replacing irrational thoughts with realistic thoughts. One way we might replace these thoughts, right, is trying to be kinder to ourselves. This is one of my favorite things I get to put up here because I find this to be very common for people at the beginning of trying to restructure these thoughts. Now, the last psychotherapeutic technique we'll talk about is this cognitive behavioral therapy, just combining the cog and the behavioral portions of this. We've got problem-focused and action-oriented. What is the problem, right? Well, look at what is causing us the problem and relieve those symptoms. So how do we do that? We can develop strategies that can be used to reduce this, and we can help change these irrational, self-defeating thoughts into more positive ones throughout this. So more or less just recognizing what we think affects how we act and feel, what we feel affects how we think and what we do affects how we think and what we feel. All of these three things do matter. Again, very biopsychosocially, kind of in that triangle aspect, but again, everything is influencing everything else. Our behaviors, our thoughts, and our emotions. Now, all of these therapies tend to be less expensive, they tend to be short-term, and we're focused on specific issues. Now, just behavioral therapy is effective for specific behavior problems, right? So if you are just anxious, this is not a good therapy for you. If you have an issue with bedwetting, overeating, addictions, or phobias, this is going to be very useful. Now, it's less effective for more serious disorders and maybe more mentally focused disorders. But on the other hand, cognitive and cognitive behavioral therapy are really good for our general kind of run-of-the-mill disorders. CBT tends to be the most common type of therapy used. So things like depression, very common, stress, eating, anxiety, all very common problems tend to be treated with some type of cognitive behavioral therapy. Now notice, though, that all focused on the symptoms, but not the cause. So we are still not exactly doing the best, but we are helping, right? So we're not thinking about what is causing those cognitive distortions. We're focusing on how to change them. So maybe not getting to the root of the issue. So with biomedical therapy, the idea is that psychological disorders are due to physical causes. So again, thinking that the mind and the brain are one specific thing, and that if we change the functioning of the brain at a biological level, we can change these psychological issues. Now, is this totally true? Maybe, maybe not. Our goal here is to change behavior, emotion, and thoughts by affecting biology, right, at the neurological level. And the therapist's role is a medical expert. So whether this be some kind of surgeon, whether this be right, doing some kind of surgery, or whether this be somebody more like a psychiatrist prescribing medication. When we talk about biomedical therapy, let's talk about maybe one of the most upsetting and unethical treatments that we have ever done on people regarding psychology. And this is the prefrontal lobotomy, right? We cut into the frontal lobe and sever connections. So if I reach over and grab if I grab my brain here, so here's my brain. So, right, if I'm sitting this way, this is, right, my eyes are right here. Oh, I've got a kitty cat. Let me pause this. Cat, go. So with a prefrontal lobotomy, what you end up doing is actually going up more or less with a very, very sharp utensil, almost like an ice pick, through either the eye or the nose. And what you do is you take this sharp object and you just kind of go right up through the brain, and then you just, lovely noise. But yes, you take off about this much of the brain, more or less. So you sever these connections of the frontal lobe, and you can see in this next picture about where it went. It was kind of forward a little bit, but this is where it originally was. Now, this was used to treat schizophrenia and depression in the 40s and 50s, and it declined as we got better using more psychoactive drugs. There were a lot of negative consequences with prefrontal lobotomies, that people did not come back as the same person. They were very different, and often couldn't do nearly as much as they could do before they were lobotomized. This picture, I think, really sells it. Right? You see the woman on the left here, who is a quote-unquote simple schizophrenia patient before her lobotomy versus after. And this was almost an ad, more or less, for this, right? If you read the top, in some instances, the best that could be done for the family is to return the patient to them in an innocuous state as a household pet. Again, this is not a very ethical thing to do. It's something that I don't really agree with psychology on, along with a lot of other things. Moving on to electroconvulsive therapy, this is another therapy that many people find to be brutal and kind of barbaric. This electroconvulsive therapy is the administration of electrical current to the brain. Now, this is done in a very safe and ethical way, where they more or less put you in some kind of anti-seizure device and lock you up, and then give you short, powerful blasts of electricity through the brain. It's controversial, but it turns out that it is effective for people with severe depression. So it is still used, but not necessarily your first line of treatment, more of a last line. Why is it effective? We really don't know. More or less, it might be kind of resetting the brain, but we're not really sure beyond that. The last type of thing that I want to talk about here is psychoactive drugs, where these are effective, but not necessarily long-lasting. Mostly we see psychoactive drugs for things like mood and anxiety disorders. However, there are things for schizophrenia, among others, but specifically for this class, focusing on mood and anxiety disorders, we've got a couple different classes of drugs, MAOI, I did say it right, inhibitors. I think those are briefly mentioned, tricyclic antidepressants, but the ones that we should know pretty well by now are this SSRIs, these selective serotonin reuptake inhibitors. Things like Lexapro, Zoloft, or Prozac, typically taken once a day, and as we remember, they cause this blockage in the reuptake of serotonin, leaving more time for these to get out here to the receptor sites and actually stay there. So more or less kind of putting a plug on that where the vesicles might come out. Now, the only other one that I think is really worth talking about are benzodiazepines, which are very useful for things like anxiety, things like Xanax or Valium. However, they are incredibly dangerous if you do abuse them. Please do not abuse benzos. That's all I ask. One last thing to mention before we end is a couple emerging treatments. The only one I want to talk about, though, is a ketamine-based treatment. So ketamine, apparently I learned it as Special K back in DARE all the way back in 5th grade, is actually very useful for shorter-term depression treatment. One way I know this, my stepmom actually was in a trial for this. She has severe depression and takes ketamine in microdoses at a secure facility in order to achieve this effect. Now, what happens, it was really interesting, is you get microdosed with ketamine for about 50 minutes, twice over 2 days, and you're good for about 6 weeks. Now, we don't know why, but one really interesting story that my stepmom told me was that the first time that they microdosed her with ketamine, she was laying in her hospital, or this kind of like hospital, or if you've ever given blood, something more like that, kind of a room with a bunch of seats. And what she said she experienced was she was flying over India with Jesus for about 50 minutes, which this is pretty cool. Plus, then you don't feel depressed afterwards. Well, no shame in that. So there are new treatments coming out that we might better understand some of the effects on the brain. But that is all I have to go over today. Thank you all very much for listening. If you have any questions, do let me know. Otherwise, I look forward to seeing you in class, and have a good one. We'll see you around.